Good afternoon, everybody, and welcome to Acentra Health's program entitled Medicare Advantage Plan Appeals in Skilled Nursing Facilities, a data-driven review of coverage decisions and clinical implications. We're so glad that you're here to learn from our data. But before we get started, I would just like to briefly introduce myself and cover a few housekeeping items. My name is Cheryl Cook, and I serve as the Senior Program Director for the Beneficiary and Family-Centered Care Quality Improvement Organization, or BFCC-QIO. Acentra Health's BFCC-QIO review authority spans over 29 states, and we serve more than 30 million Medicare beneficiaries within those states. At the conclusion of today's program, all participants will receive an email containing, information and links on how to access the PowerPoint slides and the recorded web program. To ensure clear audio, all participants' lines have been muted except for our speakers. If you experience any technical issues during the presentation, please use the Q&A feature for assistance, and you'll find that at the top on your top toolbar. Due to the length of today's program, we will not have an open Q&A session. You're encouraged to enter your questions in the Q&A tool. Our team will collect the questions, categorize those questions, and provide answers in the near future, and we will also post those to our website as well. We're very interested in your feedback on this program. We are asking for your a simple assessment and for feedback as to whether or not this program was beneficial and what you might want to see in the future. So at the conclusion of the program, you'll also receive a link requesting that input, and we just encourage you to share your comments and suggestions as they will help us to formulate future programs and also to make sure that we're tailoring those programs to the healthcare providers' needs. And lastly, Acentra Health has many resources for the provider community. These include newsletters, podcasts, a YouTube channel with helpful links. All of these can be accessed via our website at www.acentraQIO.com. So with those housekeeping items out of the way, let's get started. Before reviewing the data, we would just like to give some background information on the BFCC-QIO program. This program has three primary goals. Number one, to ensure beneficiaries receive healthcare services that meet professionally recognized standards of care. Number two, protect the beneficiary's right to an expedited review. And number three is to safeguard the physical integrity of the Medicare Trust Fund. Under standards of care, we review medical records and clinical information to determine whether or not the care that was provided was appropriate, reasonable, and consistent with accepted practices of care. This ensures beneficiaries are receiving safe and effective care while also supporting the quality improvement across the healthcare system. Under expedited reviews, the BFCC-QIO plays a critical role in protecting beneficiaries' rights to timely and fair reviews. Whenever a beneficiary files an expedited appeal or a quality of care complaint, we conduct an independent and objective review to ensure decisions are made quickly and in accordance with CMS requirements. These reviews are especially important when care decisions may directly impact a beneficiary's health, safety, or access to services. And then our third point of physical integrity. In addition to protecting beneficiaries, we also protect the physical integrity of the Medicare Trust Fund by ensuring that Medicare only pays for those services which are medically necessary and provided in the most appropriate setting. This supports reasonable stewardship of the Medicare Trust Fund dollars while maintaining the focus on beneficiary-centered care. We are pleased to welcome our Chief Medical Officer and one of our Associate Medical Directors from Acentra Health's BFCC-QIO team. Their expertise and vision continue to advance the quality of care delivered to Medicare beneficiaries and their families. First, we're honored to introduce Dr. Jessica Whitley. She is the Chief Medical Officer for the BFCC-QIO. Dr. Whitley provides strategic and clinical leadership across all medical operations. Examples of such leadership include peer review, utilization management, appeals, hearings, case management, and quality improvement initiatives. Dr. Whitley's career spans hospital medicine, physician education, care coordination, and federal healthcare programs, always with the steadfast focus on patient safety, quality, and meaningful engagement with patients and their families. She's a graduate of Case Western Reserve University School of Medicine with an MBA in Healthcare Administration from Cleveland State University. Dr. Whitley leads multiple disciplinary teams dedicated to improving healthcare quality, promoting access, and driving innovation across the continuum of care. We're also excited to introduce Dr. Angeline Burnetto, our Associate Medical Director for the BFCC-QIO. She plays a pivotal role in advancing the organization's clinical excellence, guiding strategic initiatives, quality improvement efforts, and physician collaboration. Prior to joining Acentra Health, Dr. B served as the Vice President and Chief Medical Officer for Senior Products at Blue Cross Blue Shield of Tennessee. In addition, she's held leadership positions with Humana and adjunct faculty roles. With extensive experience in emergency medicine, Dr. B brings both clinical depth and operational insight. She is a military veteran, a published author, and a committed mentor shaping the next generation of healthcare leaders. She also holds a physician executive MBA degree from Auburn University. So please join me in welcoming Drs. Whitley and Dr. Bernadetto as they lead today's discussion. Drs. Whitley and Dr. B, the virtual floor is yours.
Thank you so much, Cheryl. I appreciate that introduction. This is Dr. Jessica Whitley. I will start the presentation, and then I am going to be pleased to hand it off for a little bit to Dr. Burnetto, who is really so pivotal to the work that we do, and that has been extremely helpful to me as our medical director overseeing the appeals department. I would like to welcome you all today. Good afternoon to you. I thank you for joining us. We're going to discuss our findings of a focused review that we completed examining Medicare Advantage plan appeals in skilled nursing facilities. Of course, we refer to skilled nursing facilities at times as SNFs. So if you hear me say SNFs, I mean skilled nursing facilities. We are deeply committed to the pillars that Cheryl Cook, our esteemed program director, who we really would just be lost without. She makes sure everything, the I's are dotted and the T's are crossed. So I'm very thankful for Cheryl Cook. And those pillars that she just outlined are critical to the work that we do. Central to our mission is knowledge sharing, because improving quality of care for Medicare beneficiaries begins with transparency, collaboration, and shared understanding. And in today's session, we've designed it to do exactly that. We will begin by walking you through some background data, such as trends and patterns that first signaled us that a focused review was necessary. We're then going to discuss the purpose of this particular focused review and what we set out to learn by conducting this review. Next, we're going to share what we found And we're going to summarize what those findings tell us about current practices and their impact on beneficiaries. And finally, and what I might say most importantly, we're going to present some action-oriented recommendations that are aimed at advancing our shared mission to improve the quality of care for all Medicare beneficiaries. Next slide, please. So let's take a look at some data trends that were reviewed by the BFCC-QIOs, by this BFCC-QIO. So appeals stands out as one of the most critical review types that we perform. Why? It's because appeals happen in real time and they directly impact beneficiary care. At its core, the appeals process exists to protect beneficiary rights and to ensure that beneficiaries receive care in the most appropriate setting based on their clinical condition. It's important to help you to understand, these outcomes are not just abstract. They're not retrospective. They're in real time. They can and often do shape a patient's recovery trajectory from both acute and chronic illnesses. When we examined our appeals data, one trend really stood out. Now, this is not depicted on this slide, but I'm going to give you a little bit of background and then get into the slide information. 83% of all appeals originate from the skilled nursing facility setting, from the SNF setting. This is particularly notable given that we process approximately 25,000 appeals each month. Now, when we look more closely at our SNF-related appeals, this is a striking pattern that kind of just smacked me across my face. 93% of SNF appeals come from Medicare Advantage beneficiaries. Now, this is despite the fact that Medicare Advantage penetration in our population is about equal to that of the fee-for-service beneficiary population. The Medicare Advantage penetration is about 52% among our 29 states. Now, this disparity suggests that Medicare Advantage beneficiaries, and let me just say, sometimes I'll refer to Medicare Advantage as MA so that I can shorten some of my sentences for you, but also refer to MA. These Medicare Advantage beneficiaries, based upon these appeal differences, I mean, it's a pretty big difference, 93% versus 7% appealing from the SNF setting. So it indicates to us that MA beneficiaries are far more likely to feel that notices of Medicare non-coverage, or NOMNCs, as we refer to them as also, that these notices to end their SNF services are being issued before they are clinically ready. Now, by comparison, we see fee-for-service beneficiaries account for only 7% of SNF appeals. And remember, their overall enrollment is pretty much equal. So that disparity caught our attention and we wanted to look into it further. Another thing that we noted, and this is based upon a trending of all appeals that we have done contract to date. And that's why you see the date here indicated between May 2024, which is when this contract cycle began, and this data ended, we tracked it through April 2025 because that's when we began this focus study. So another trend that we noticed between this time was the fact that when Medicare Advantage beneficiaries do appeal, we disagree with the NOMNCs nearly half the time, 48% to be exact. And so this indicated to us that many of these notices may not reflect the beneficiary's true clinical condition. Because if it does, why are we disagreeing with these notices so frequently? I want to make sure I let you know that these reviews are completed by actively practicing physicians, meaning they practice on average 20 hours per week. They are not employed by Acentra Health, but they are independent contractors that are trained on all Medicare guidelines extensively. All of these physicians are board certified, and they're in good standing with their practice. So these are practicing physicians who have no team in the game, right? Their team is the beneficiary, to look at the clinical facts, to apply them to the Medicare guidelines that govern the coverage determinations for the setting that the beneficiary is in. In particular, this setting that we're talking about today is the SNF setting, skilled nursing facility setting. And those guidelines are available for anybody to review in the Medicare Benefit Policy Manual that is available online. And these guidelines are in Chapter 8 of that Benefit Policy Manual. So these are the guidelines that we make sure our physicians know and that we teach them based upon. And then we do frequent audits of these physicians. And Dr. Brunetto is an extreme help when it comes to that, to make sure that our physicians are making correct determinations. I will tell you that Dr. Brunetto was recently hired by Acentra Health about 6 months ago. And one of the things that got me particularly interested in Dr. Brunetto was her Medicare Advantage background. She was the chief medical officer for a large Medicare Advantage plan. And I want to always have the perspective. Our goal is to get patients having their care in the right setting at the right time based upon their clinical condition. So we are not trying to find in favor of the beneficiary over the MA plan or in favor of the MA plan over the beneficiary. We are looking at the clinical facts and applying those to the CMS guidelines. So I wanted to just put that all out for transparency and how we conduct these reviews, and to let you know that we try to look at them from various perspectives, look at the guidelines and make sure we're applying the guidelines to the clinical condition of that beneficiary as outlined in their medical record. Now, another troubling pattern that we noted is for Medicare Advantage appeals, 27% of those were because of repeat nomnics. That means these nomnics were issued within the same episode of care. So in these cases, beneficiaries had already won a prior appeal, and then they receive another nomnic during the same SNF stay. In this study that we did, there were some beneficiaries, and Dr. Brunetto will discuss this later, that received up to 12 nomnics within the same stay, often just repeated on regular intervals, like weekly intervals. So when we did review, when we get these repeat appeals, we look at our disagree rate. And that climbed significantly from initial appeals. It went from a 48% disagree rate to a 77% disagree rate. Now, when you look at fee-for-service, only 11% of fee-for-service appeals involve these repeat appeals. So this is another data point that drove us to say we wanted to take a deeper look and do a focused review. Next slide, please. Now, another trend that prompted this review was mobility at the time notice of Medicare non-coverage was issued, or NOMNIC. Listen, mobility is not just a functional measure. It really is a powerful indicator of patient safety, recovery, and readiness for discharge. And when we examine mobility status, the difference between MA plans and fee-for-service beneficiaries were significant. Now, we tracked and trended many key mobility indicators. Right now, we're presenting walking distance or their ambulatory function, and we're doing that for the sake of time. If we got into all of the mobility indicators that we looked at, this call would be hours. So for the sake of time, we're only going to discuss ambulation on this slide, and we will discuss some bed-to-chair mobility on a later slide. So at the time of NOMNIC issuance, MA beneficiaries demonstrated a 98% increase in significant walking impairment compared to their prior level of function. What do we define as significant walking impairments? We define that as a beneficiary who at the time the notice is issued is able to walk less than 50 feet, when their prior level of function, they were able to walk greater than 100 feet. So they've lost significant mobility. Now, when we look at fee-for-service beneficiaries, they also experienced a decline in their ambulatory function or walking function, but at a much lower rate, 67%. So while any loss of mobility is concerning, the magnitude of the impairment seen among MA enrollees raised some serious questions about, are these NOMNICs being issued before patients reached a functional status that no longer required daily skilled care and did not pose a risk of clinical decline if those daily skilled services were discontinued at the time the NOMNIC was issued? Now, these findings are really concerning because mobility is very closely linked to fall risk, injury, and hospital readmission. So issuing NOMNICs, if that is happening at a time when beneficiaries are functionally impaired and truly need that continued daily skilled care, this can interrupt recovery. It can place beneficiaries at serious health risks, and ultimately it can lead to poorer outcomes. Next slide, please. We also looked at length of stay, and this is also contract to date data. Up to this goes all the way to October 2025, as you can see. So although we noticed this trend before we started the focused review, we just continue to show you what we're seeing now. So if you look at length of stay differences between MA plans and traditional fee-for-service beneficiaries, and this is demonstrated in this slide, when we compared the average length of stay, we found that MA beneficiaries had stays that were 36% shorter on average than their fee-for-service counterparts. Now, does this mean anything? Absolutely. I've talked to lots of MA plan medical directors, and they say, well, we're just more efficient in the way that we deliver our care. And is that true? Well, we won't discuss that on this call. But perhaps at a future time, we're going to look at these outcomes. So just stay tuned. There's more to discover and unpack. Now, but what's really important about what I'm showing you now is looking at the trend lines. The difference isn't just in the length of stay, it's in the pattern. The fee-for-service line shows clear variability over time, ranging roughly from mid-30s to mid-40s in days. You can see peaks, you can see dips that suggest responsiveness to patient complexity, recovery progress, and clinical need. In contrast, it was concerning that we noted that MA plan length of stay, the line is strikingly flat. Month after month, it remains clustered in a narrow range, generally around 25 to 27 days, with very little variation. So why is there this lack of variability? We wanted to try to understand. It's important that you understand that when we see a length of stay that looks nearly identical across months and across beneficiaries, it concerns us that administrative timelines may be playing a larger role than individual clinical status in determining when NOMNICs are issued. Next slide, please. Now, beyond our own internal findings, it's important to take a step back and look at what's happening nationally. Now, Medicare Advantage has fundamentally reshaped the Medicare landscape, More than 30 million beneficiaries, which is just over half of the entire Medicare population, are enrolled in Medicare Advantage plans. And projections suggest that that number will grow to 62% by 2033. With that rapid expansion of Medicare Advantage, there have come some growing concerns. And this is particularly around quality of care and access to medically necessary services. And this is especially in the SNF setting. One of the most frequently cited issues is an inappropriate and repeated issuance of notices of Medicare non-coverage. Now, the Center for Medicare Advocacy, which really monitors Medicare beneficiary concerns, they are also the organization that was behind the landmark GIMO lawsuit against the Department of Health and Human Services. So they have reported a growing wave of complaints from Medicare Advantage enrollees who believe their coverage is being terminated prematurely. At the same time, if we look at a legal spotlight, that is intensifying. On classaction.org, it was announced that there are investigations into major MA plans over allegations that coverage termination decisions may be driven by flawed algorithms rather than individualized clinical judgment. So these judgments should be guided by physicians and patient-specific needs, not just based upon algorithms that primarily rely on timeframes. We are not saying that this is in fact true, but this is information that is published and that has raised substantial concerns. So it presents an onus on the BFCC-QIO, who has a role of beneficiary protection, who has a role of ensuring quality of care to beneficiaries, and who also has a role to protect the Medicare Trust Fund to look into some of these trends and concerns. So as we set the stage for this focused review, here's the message, and it's clear. The stakes are high, scrutiny is increasing, and the impact is very real, not just for MA plans and skilled nursing facilities, but most importantly, for the beneficiaries and families who depend on this care. Next slide, please. Now, this slide outlines the purpose behind why we conducted this focus review, and it really centers on one overarching question. Are Medicare beneficiaries receiving medically appropriate, patient-centered care in the skilled nursing facility setting? So we set out to investigate concerns about premature termination or the attempt to prematurely terminate medically necessary services in a SNF setting by MA plans. Specifically, we wanted to evaluate whether NOMNICs were being issued too early or inappropriately without adequate consideration of the beneficiary's clinical needs, recovery trajectory, and their functional status. Second, we examined the adequacy of care planning and implementation within the skilled nursing facilities themselves. This included assessing how well the care goals were established, how therapy progression was documented, and whether or not nursing and interdisciplinary interventions were aligned to support recovery. You know, strong care planning is essential, not only for patient outcomes, but also for accurately demonstrating ongoing daily skilled needs. So, you know, we didn't just look at MA plans, we're also looking at SNFs in their care planning of beneficiaries, because we're trying to find information that can inform a broad audience of stakeholders. So finally, we also looked beyond some clinical factors, and we looked to identify non-clinical influences on NOMNIC issuance. In particular, we wanted to examine whether or not there was indicators of algorithm-driven decision-making and situations where coverage terminations appear to lack that individualized input and assessment of the patient's clinical condition at the time the NOMNIC was issued. So by understanding where some of these processes may break down, whether at a plan level, the facility level, or both, we can better support, care that's timely, appropriate, and really truly centered and focused on the needs of the beneficiary. Next slide, please. So this slide presents the first result. Of course, we have a lot of results that we found, but again, limited by time, we're going to present certain results here. So this slide helps to illustrate one of the most important gaps we identified in the review. And that gap is the disconnect between what beneficiaries were expected to achieve as demonstrated by what the goals of therapy were. And on this slide, we have walking distance goals and bed to chair transfer goals. Those are noted by these yellow bar graphs. So we wanted to understand the disconnect between the goals that were established and the actual functional ability of Medicare beneficiaries when those NOMNICs were issued. And their functional ability at the time of NOMNIC issuance is represented in this blue line graph. So let's start with looking at this. As you can see, the majority of beneficiaries had goals that reflected meaningful functional recovery. In fact, the majority of beneficiaries had a walking goal of 100 feet or more and a goal for independent for bed to chair transfers. Now contrast that with the line graph, or the line on this graph that overlays those bar graphs, and it can compare and show the actual walking and transferability at the time of the initial NOMNIC with the goal. And you can see the gap is significant. It shows that many of these beneficiaries were still far from achieving their established mobility goals when the NOMNIC was issued. And we're talking about initial NOMNICs here. Now, it is very important for me to clarify, because a lot of you, I can just sense the thoughts going on in our attendees. Let me just clarify right now. Beneficiaries are not required to fully achieve therapy goals at the time that they are discharged from a skilled nursing facility. So in many cases, once a beneficiary reaches a certain level of stability, continued therapy in progress can safely occur without daily skilled therapy services, and therefore not in a skilled nursing facility setting. However, when we compare established therapy goals to the beneficiary's actual functional status at the time a NOMNIC is issued, remains a critical part of assessing whether or not coverage termination is appropriate. These therapy goals should not be arbitrary. They are developed by the clinicians, by the skilled therapists who have physically evaluated these beneficiaries, who understand the beneficiary's limitations and their potential for recovery. So in other words, these goals should reflect what trained therapists and trained clinicians believe is reasonably achievable for that individual. Therefore, when we see a large gap between a beneficiary's functional status at the time of NOMNIC issuance compared to the goals that were established, it's going to raise some important questions. One, we are going to ask, were these goals unrealistic to begin with? Or is the beneficiary, or is that NOMNIC being issued well before their functional potential is reached that represents a point where daily skilled services are no longer medically necessary to achieve safe and sustainable mobility? And this distinction matters. If a beneficiary remains far below their anticipated level of function, Ending daily skilled services may place them at increased risk for functional decline, for falls, or readmission once therapy intensity is reduced or removed altogether. Next slide, please. Why is mobility just so important? And I really want to emphasize this. And in my reading of standards of care that are out there, and my reading of medical literature, it's important to note that as the U.S. population continues to age, functional limitations and disability are becoming increasingly common among older adults, which is our Medicare population. These limitations are not just affecting movement. They are directly impacting a person's ability to perform essential activities of daily living, such as walking, transferring, being safe, preventing future falls and future injuries. Therefore, mobility it's more than a physical measure. It's a foundation for independence, safety, and quality of life. When mobility declines, beneficiaries are more likely to experience falls, require caregiver assistance, and they may just lose their ability to live independently. Now, the importance of mobility, I think, is highlighted because the World Health Organization recognized functioning, and that's quote unquote functioning, and that's what the World Health Organization considers the key third health indicator. This is right alongside morbidity and mortality. And mobility is one of the strongest indicators of health outcomes and quality of life for older adults. When disability sets in, it's going to drive costs higher, thereby increasing costs to the Medicare Trust Fund. It's going to create greater caregiver burden, and it's going to create worse outcomes for patients who will often experience readmissions and continued health decline. So rehabilitation in SNFs is critical because it restores function, it's going to reduce the need for long-term care, and it can even lower mortality. Next slide, please. Now, I wanted to present the admitting clinical diagnoses for our study population. Because when I presented to you earlier and I discussed the fact that in this population that we're studying, we only looked at those beneficiaries who had significant mobility impairments. And I'm going to define that again to you. That means before the onset of the illness that resulted in this SNF admission from their hospital stay, these beneficiaries were able to walk greater than 100 feet. But at the time of the issuance of the initial NOMNIC, they could walk less than 50 feet and they couldn't use a wheelchair. This is excluding people that are able to safely ambulate in a wheelchair. So they're not wheelchair mobile and they're walking less than 50 feet. And oftentimes these beneficiaries are requiring, they're requiring at least minimum assistance to walk less than 50 feet. So that's the population that we were studying. And so when I talk to you about most of these beneficiaries having significant mobility impairments, I'm going to tell you one of the things that I thought about initially was, well, maybe they had a catastrophic medical event. Maybe they had a stroke. Maybe, they had an amputation, severe trauma, but that's not true. If you look at our admitting diagnoses, only 6% had some type of neurologic event. So those patients, I could see that they're going to reach a new level of functional performance that may be significantly lower than their original or prior level of function. Now, after I go through that, what I want to highlight to you from this data is the fact that falls alone accounted for about a third of all the cases we reviewed. And this number just really demonstrates how significant the issue of falls is. And remember in the beginning, I told you, I wanted this presentation to inform action. So in this study, it's consistent with literature findings. So for older adults, especially those 65 and above, a fall is not just an accident. It can often be a life-changing event. If the falls can lead to major injuries, long hospitalizations, lasting functional decline, and that's why falls is a serious public health concern within Medicare, and it represents significant annual costs. But what I want you to see from this and what I want you to know is that falls are not inevitable just because our people are getting older. There are preventative strategies that can make a real difference. And we'll talk about the importance of these preventive strategies in our recommendation. But I want to emphasize at the time that you're seeing this data that we have to put energy in interventions that focus on home safety evaluations, physical therapy to improve strength and balance prior to the onset of an illness. Like, we also have to look at medication reviews. Have we looked at vision checks? That all of these things can dramatically decrease fall risk. Next slide, please. And I'm going to hand this over to Dr. Brunetto to discuss these next slides. Dr. Brunetto, handing it to you.
All right. Thank you, Dr. Whitley. Hello, everybody. All right. So some of the results that we're looking at here that led to the questions that we had is demonstrated on this slide. So this says length of stay, but this isn't length of stay as far as overall for the beneficiary remaining in the skilled nursing facility. This is length of stay to the time that the initial NOMNIC was issued. And if you're looking at the three categories there, you're seeing that these represent three different MA plans. And what we noticed when we were looking at the data is that there was more collective or a higher concentration of NOMNICs being issued at the 2-week range, so roughly 15 days, and then again at 20 days. And this wasn't just within one MA plan, this was actually in the majority of them. And that led to the question is, okay, are there administrative review cycles or are there algorithms that are playing a role in this? And that's why these NOMNICs are being issued, and we're just not finding the clinical information to be supportive of them. So that actually raised the questions for us that we were hoping to answer. All right, next slide, please. And Dr. Whitley touched upon this already, the repeat NOMNICs. Now, in this study population, we went ahead and looked at the total number of NOMNICs that were issued for each beneficiary. So the first NOMNIC was issued. The QIO took a look at the clinical information and determined the criteria was not met, and therefore the beneficiary won their appeal, and they were allowed to stay in the skilled nursing facility. On average, each beneficiary had 2.7 or almost 3 more repeat NOMNICs. And as Dr. Whitley stated previously, one beneficiary had up to 12. Now, one of the things that we're going to touch on is we understand that, the plan is, are they ready for a lower level of care? Are they ready to be discharged? But the question that needs to be answered is, has anything changed in the beneficiary status? If you've issued the first NOMNIC and it's determined that the criteria has not been met, that they really should stay, that they would benefit from daily skilled therapy services, to reissue the NOMNIC that day, the next day, or within just a couple of days of the issuance of the first one, it's confusing. And there's really a lot of times no new information. We found that this is, of course, an administrative burden for not just the plans, but also for the skilled nursing facilities. And it creates confusion for the beneficiary and for their representatives. Okay. Next slide, please. So when we're talking about the repeat NOMNICs, Dr. Whitley touched on the CMA, or the Center for Medicare Advocacy. In 2022, the CMA issued an alert about an alarming increase in complaints from MA enrollees. And this was regarding initial and repeat NOMNICs that they felt were inappropriate. So to help the MA enrollees push back against that spike in improper denials of Medicare coverage, The CMA drafted a grievance form, and this actually helps the beneficiaries file complaints against the MA plans issuing inaccurate and repetitive MA plans. And then CMS weighed in. CMS updated its appeal guidelines, and they included a significant change to the appeals process. Effective on January 1 of 2025, the detailed explanation and non-coverage, or DINCs as we know them, have to include the following elements for the plans to complete. So if the enrollee had previously received a favorable NOMNOC appeal decision from the QIO during the current episode of care, then there needs to be detailed documentation of the specific changes in the enrollee's condition since the previous appeal that provides the basis for this decision to terminate services. So simply said, or in other words, what has changed in the enrollee status since the previous NOMNIC was issued that justified termination now, that justifies termination of their daily services at this time? It should not be the same clinical information that was submitted with the previous request. All right, next slide. Okay, our key findings. So when we took a look at everything, when we pulled everything together, there were certain details that jumped out to us. And these are the top 5 that we noted. So 92% of the beneficiaries required continuous skilled nursing or therapy services at the time that the NOMNIC was issued. And that was demonstrated just in the determinations that were made by our physician reviewers in which they disagreed with the NOMNIC being issued at that time. The study found that most beneficiaries were still clinically assessed as needing daily skilled care at the time of their, they were still needing daily skilled care at the time that their coverage was slated to be discontinued. Despite the clinical need, 72 beneficiaries were considered vulnerable to negative outcomes if they were discharged prematurely, and this raised concerns about the appropriateness of the NOMNIC timing. Again, that's getting back to, are there administrative or algorithms in place? Are these individuals truly being assessed for their physical, what are their current capabilities? Have they met their goals? Are they still requiring daily skilled therapy? Are they at risk of decline if they're discharged? And as Dr. Whitley pointed out, with the World Health Organization in falls, the #1 admission diagnosis was falls. And if they're going to be discharged prematurely, that actually contributes to further injury or decline once they go home. The data also showed that NOMNICs were frequently clustered around day 15 and day 20 of the SNF stay, as I stated. And that suggests, I'm not saying that that's the case, but it suggests that NOMNIC decisions may be driven more by administrative timelines than actually individual patient progress. So this could potentially lead to premature termination of coverage. And one thing to point out in this study, these were the beneficiaries that appealed. This isn't all players. This isn't the folks that got a NOMNIC and were actually discharged. These are the folks that appealed and won. Okay. Many beneficiaries received multiple repeat NOMNICs, as we stated, up to 12 in some cases. This places a burden on the beneficiaries, their families, and the SNFs. Of course, there's the administrative burden of the documentation and the submission, but you have to think about the emotional toll of the beneficiary and their families. Many times we hear where they don't understand that they won an appeal, and then just a few short days later, they're receiving another one, and they feel that they can't focus on improving if they're constantly having to, I guess, express their concerns with the administrative aspect of being able to stay in the facility. And then the other piece of it is the widespread deficiencies in SNF care planning and documentation. Nearly 40% of the beneficiaries lacked individualized care goals on admission. And that's really concerning, because if they're being admitted to the facility for daily skilled therapy, you would expect there to be a care plan in place as far as what is the current level of function, what is a reasonable goal and expectation, and how are they working to achieve those goals. And if they're not progressing, or if it seems more realistic to change those goals, that documentation should be in place. You would expect that to be updated. the goal should be reasonable. So CMS expects that there is sufficient documentation to support the claims, timeliness and completeness, and medical necessity needs to be demonstrated. So the documentation must establish the medical necessity of services provided. So this includes updating the treatment based on the client's progress and their therapeutic needs related to their condition. Next slide. Okay, so for the MA plans, the recommendations, of course, are to align the NOMNIC timeliness with clinical recovery. Instead of relying on rigid number of day-based reviews, let's shift truly to evidence-based, personalized recovery plans for the NOMNIC issuance. And this approach ensures decisions are grounded in real patient needs, not just arbitrary timelines. This will drive more meaningful changes that align with Medicare Advantage practices with what truly matters. And this is safe, clinically appropriate discharges that put the patient first. Education and collaboration. Let's empower the SNFs and the MA plans with continued training on NOMNIC guidelines, documentation, and beneficiary protections. At the same time, collaboration is key. It's difficult in medical practice now because there's a lot of things that are disjointed, and communication between the SNFs, the MA plans, the teams, the nurses, beneficiaries, everybody, truly bringing everybody together on the same page to ensure discharge planning is truly coordinated and patient-centered would have the best outcome. And then lastly, promote equitable access to rehabilitation services. We need to make sure that every Medicare beneficiary has fair access to the rehabilitation they need without barriers of bias. And when you compare the fee-for-service with the MA plans in this patient population and in our study, you see that there's a discrepancy between the two. So what this means is upholding CMS's standard. MA plans should offer coverage that's equal to or better than traditional Medicare. And decisions should never be driven by cost cutting at the expense of care. All right. And then I'm going to turn it back over to Dr. Whitley to wrap this up.
All right. Thanks so much, Dr. Brunetto. I do want to add some additional comments to what Dr. Brunetto said about how we structured this study. And I think we have a little bit of time. I wanted to get into that earlier, but I was worried about running out of time, and I hope I don't run out of time because I'm telling you about this now. But what we did was we took a population of appeals that had already occurred, and the appeals had the notices of Medicare non-coverage were disagreed with by our actively practicing physician. So they disagreed with the NOMNIC, meaning that they felt that the beneficiary's clinical condition still indicated the need for medically necessary therapy 5 days a week in a skilled setting. So what we wanted to do, again, in the beginning, I presented to you that for MA plans, their initial disagree rate for all appeals coming from the SNF setting is 48%. 48%. And we wanted to say, okay, this is what we're getting from our physicians. Why is this disagree rate so high? Because we should be closer to this on the same page. We're operating by those same guidelines that are in Chapter 8 of the Medicare Benefit Policy Manual. Why is there that discrepancy? So we wanted to take a closer look at a subset of these appeals for beneficiaries who had significant mobility deficits. Remember that it's the subset of population that has significant mobility deficits. We focused on that population because we felt that they were most vulnerable to a decline in their clinical condition if they were discharged at the time that that NOMNIC was issued. So although physicians did the initial review and had the initial disagree, what we did for this focus study is we got occupational and physical therapists and clinical nurses who have extensive experience in SNF care, and we wanted them to look at it. They didn't understand what our determination had been. But we not only wanted them to look at the records, but we asked several questions to try to identify where issues may exist. So 92% of the cases that we reviewed, and there, 92% of those reviewed, the therapists found, or the nurses, it was either based upon therapy needs or on skilled nursing needs. That's one thing I really want to emphasize. And I saw this in the study, and I also see it across appeals. Please do not issue NOMNICs just because a patient does not continue to need daily skilled therapy. Skilled nursing is also a discipline that a patient can require daily services, and for skilled nursing, that's 7 days a week as opposed to 5 days a week for therapy. But please don't just look at their therapy needs. We also have to look at clinical needs from a nursing perspective. So on 92% of these cases, so we're having a 92% inter-rater reliability with our physician reviewers that are saying these patients are not ready for discharge, and 72% of those reviewed were at a high risk of clinical decline if they would have been discharged at the time of that initial NOMNIC issuance. That's really important for us to recognize, and I just wanted to give you that additional fact so that you know that we did not just have one person look at these reviews and go based upon that one person's review. Basically, you had 3 skilled professionals, physicians, therapists, nurses that looked at the records, and these were the conclusions. So what do we recommend? All right, now I'm back. Now I'm back on track. I went off a little bit, and I'm going to wrap this up because I know my time is going. But here are some key recommendations. And this is for the skilled nursing facility. We wanted to give recommendations that are tailored to all potential stakeholder groups that may be attending this call. First is goal planning and updates. It is essential that SNFs and the therapists that are working in those SNFs develop individualized and achievable goals that are tailored to each beneficiary's clinical condition and prior level of function. These goals need to be reassessed regularly, and they need to be updated based on how a patient is performing. If progress is stalling, if patients are not meeting goals, it is important for that patient to be reassessed to then determine if the goal that was initially set remains realistic. If that goal is no longer realistic, and when it no longer reflects the beneficiary's status and potential, then the goal needs to be changed. And it needs to be changed that, discontinue the initial goal and you update that goal to a new goal that is more in line with what you see from that beneficiary currently. You cannot set treatment at one point in care, at the beginning of that care, and you need to be able to adjust that treatment goal as you see how a beneficiary is responding. And that goes into the treatment planning and updates. Please, treatment of patients is not static. We have to always look at how a patient is responding to our therapeutic interventions, to what our goals are for those therapeutic interventions, and we need to modify either the goal or the therapeutic intervention, and sometimes both, to achieve a result that is a reasonable result for that patient to achieve safety on discharge and a low and no significant risk of decline. So that is very important for SNFs to understand, for therapists and SNFs to understand. We also want to emphasize the importance of interdisciplinary coordination. Dr. Burnetto discussed that it's essential for the SNFs and the MA plans to coordinate. It's also essential to coordinate with beneficiaries and or their caregivers. Beneficiaries should understand these are your goals. This is what we're trying to reach. This is where we're trying to achieve for you to be able to safely go home. They should understand you may not get to your prior level function, but we are trying to get you to a level of safety where you no longer require daily skilled care. And that way, beneficiaries can discuss their concerns for those goals early in their care trajectory rather than at the time that they receive a NOMNIC. And please, please indicate what's going on in your clinical documentation. We do not have the benefit as the BFCC-QIO to look at your patients. We don't come on site and treat your patients. We are expecting, and what CMS requires is that documentation be proper and it inform and it presents a picture of what is going on with patients clinically, what's being done for patients, what their clinical status is, what the potential barriers to their care may be, and for that medical record to have an accurate and updated reflection of what's going on, what's being planned for discharge, what are discharge needs. If a patient has had a significant illness or injury where they may be reaching a new functional baseline, it is important to make sure that teaching and training is provided to that beneficiary and caregiver so that they understand how to now safely mobilize at a functional status that is much lower than what their prior functional status is. And finally, to our beneficiaries, caregivers, or to agencies that may be representing them, please encourage beneficiaries to be actively involved in their care. Inform them that they want to start making sure they're strong and they're undergoing prehab, not just rehab. Keep your mobility. Do exercises prior to when you get sick so that you have resolve and some reserve at the time that you're getting sick. When you're choosing a skilled nursing facility, look at the data that CMS is publishing with the Healthcare Compare and the STARS program. Look at outcome measures that CMS is publishing. Make sure that if a facility is not engaging with you, that you prompt that engagement, that you ask, what are my goals? Where are we trying to get? What is my expected discharge date? Where do you think I will be to be safely discharged? And then make sure you've been given all the instructions that you need on discharge, that you have been provided an accurately updated medication list to know if any of your medications have been changed, to know what your follow-up appointments will be, to know that this is the durable medical equipment that I'm supposed to have and make sure you're getting that, to know if you're supposed to be getting home health, that has been arranged. Next slide. So in conclusion, and I apologize for going 3 minutes over, we would like to thank you. Look, the center of our work is Medicare beneficiaries. These beneficiaries are relying on all of us to take care of them during some of their most vulnerable moments. We encourage you to take what you've learned today, take it back to your organization, your teams, your daily practices, the beneficiaries that you may advocate for. Beneficiaries, if you're on the phone, take this and take it to your care settings. Ask hard questions of what your processes are and what they need to be. Beneficiaries, speak up when you think something is not going right. Let's partner more across disciplines. And most importantly, let's keep the beneficiary at the center of all of our decisions. Thank you for your time, your attention, and your continued commitment to improving quality of care.
Thank you, Dr. Whitley and Dr. Burnetto. At this point in time, I believe we're going to put the link for our feedback in the Q&A. We would strongly encourage our participants to give us feedback. Tell us how this information is beneficial to you. Tell us what you'd like to see in the future. We'd greatly appreciate that. So with that, we're going to conclude our call. We will make this recording available. We will also provide you the slides at a future date. And we just really thank you for your participation today. Goodbye, everybody.